Welcome to Limbwalkers podcast from the JED TV studios on the campus of Purdue Northwest in Hammond, Indiana. Now here's your host, Will Glaros.
Hey everybody, have you been hugging that tree? You're afraid to take some risk, and then all of a sudden you're like, well, maybe I want to walk out there, but I don't even have any guidance or anything. Well, you need to listen to the Limbwalkers podcast. It's L-I-M-B Walkers, anywhere on any podcast service. And it really kind of follows the general philosophy about life, and it's been a very eventful life of Will Glaros is sitting to my right now. Will?
Hey, Jimmy, how you doing?
I'm doing great. It is it's a different day. We're recording this one on Tuesday, October 1st of 2025.
Wednesday.
Is it Wednesday?
It's Wednesday.
You know what? I'm going on vacation on Friday, so I'm like already kind of in that mode already. But as you guys well know, we record these live if you are listening on WJOB AM and FM radio. We're also on YouTube and a bunch of other places. So thank you for listening live. But ultimately, you'll be able to get this podcast on Apple, Spotify, wherever you get your podcasts. We have a special guest today.
We do, and actually he fits right in with the title of this program, Limbwalkers, which, Jim, just to remind the audience, is our opportunity to bring people to them and personal stories to them and other areas they can go to get that extra lift to help them walk away from the trunk of the tree of life and take some adventure, go out on the limb and do some things normal people wouldn't do. And today we definitely have a limb walker. In fact, I'm going to talk about two limb walkers. One was myself, because all along through my life, instructed by my parents to have the faith that when you try something, do it, believe in people, believe in things. And that actually came to a paramount position in my life about 3 years ago, when just about this time my cardiologist told me that I was probably going to need to have open heart surgery. And I began to imagine having this crack in my chest and all that goes with it and everything. And I had looked at some people locally here, and then my wife, by fate, ran into a friend of hers who used to work in the surgical operatory for the heart division at University of Chicago, and she introduced me to our guest today, Dr. Hussam Balki.
Let's bring him in right now. Doctor, thanks a lot for zooming in with us. Where are you zooming in from?
Chicago.
All right, that's like 150 miles from here, is that right? No, you're about...
a little bit, not too far. Downtown, I'm just about to go to my clinic in Streeterville, which is where I met Will for the first time. When was it, 2022 maybe?
22 is when we had it done in 22, because I was just looking. I went online to my chart today, and I had seen my doctor in about September, October, and then we had the procedure done December the 15th. 2022.
What procedure was it, Doc?
So, Will, are we okay sharing your...
sure, that's fine.
Will has...
I want to inspire people to have the faith to do the things they think they need to do.
Yeah, we got to make sure we're HIPAA compliant.
Yes. Yes.
So Will had a blockage in the main blood vessel that feeds the heart muscle. It's called the left anterior descending. Some people have other names for it, which I don't like to use, but it is the most important blood vessel that we harbor in our bodies. And he had a critical blockage that put him at risk for a major heart attack.
And how do you get rid of that blockage? And we could talk in general terms or whatever, but what's the preferred technique to get rid of that blockage?
Well, it depends on, a lot of different things, including the location, the contour, the configuration of the artery, the complexity, if you will, of the blockage. Does it involve a branch? Does it not involve a branch? Is it very high up? But in general, most heart doctors, whether they are surgeons or cardiologists, will tell you that the best way to deal with it is to use an artery that we were given as a spare part. I call it God's given spare part for the heart. And it's an artery that lives right under the breastbone. And when this main artery on the heart is blocked up, why we've learned over the last 50 years of heart bypass surgery that we can tease that artery off from under the breastbone and plug it beyond where the blockage is and just reroute the blood flow. And that has been shown over the last 50 years to be the most durable solution for a blockage that occurs in this artery.
In fact, I'm sorry, go ahead.
Well, I was going to say there are other solutions like stents. You can do an angioplasty, which means blowing up a balloon inside the blockage to make it less blocked, or you can put a stent, even a metal stent, to keep it open. But those things have been shown time and time again to be inferior to the surgical option of bypass. Now, the one thing that makes the bypass not the most desirable option is that traditionally we have had to crack somebody's chest open to do that. And that's why you find that a lot of patients would end up getting a stent because of the invasion of a traditional operation.
Where does robotics come into this?
Yeah, so what robotics did, it basically revolutionized the act of doing this bypass. So what the robot can do, it can allow the surgeon to have articulating hands inside the patient's body cavity, whether it's the chest or the abdomen or even sometimes, the neck. Robotics is becoming a very, very commonplace thing in all of surgical specialties, and now lately including the heart. And so what the robot does is it allows the surgeon to have articulating hands inside the chest that can execute this operation very quickly within 2.5 to 3.5 hours, and not invade the patient's body, not open the chest, not saw the sternum open with a saw, and therefore the patient's recovery is extremely quicker. They go home. I don't know, Will, you may have gone home in the first day or two after surgery, and then getting back to activity is significantly enhanced, where there's really not a whole lot of downtime, maybe a week or two.
Actually, maybe I set the record. We had that procedure, I think, on a Thursday. There was a miscommunication for release from the hospital, and I think I was released on Saturday finally. On Monday morning, I actually got up and did my almost full physical fitness regime that I do 6 days a week.
There you go.
And that was after being under the procedure for, as you said, 3.5, 4 hours.
So, Doctor, can we go at what Will and other people would be going through in this? I mean, certainly there's a physical aspect. We've actually, I think, covered this on a different medical show on the use of robotics. I know there is a term you don't like to use, and I won't use it, but this is as sensitive as it gets and so forth. But now you have a man like Will going into this robotic procedure. They're a little worried. They're a lot worried. Their family's there. They're sending them that kind of stuff. What do you tell these patients as they're getting ready to go into this robotic procedure?
Well, for this specific one, we tell them that the prognosis is excellent, that the likelihood that we have to convert, i.e. we have to then open the chest because of some nuance or complexity that was unexpected, is extremely low, less than a fraction of a percentage point. We've been doing this operation and we've pioneered it to some extent and have the largest experience with it. It's called TCAP, totally endoscopic coronary artery bypass. And we have the largest experience in the world here at University of Chicago in my program. And I tell the patients that the likelihood of success is extremely high, and you're going to be hopefully in and out of the hospital. One of the aspects of this that makes it very benign to some extent, comparatively speaking, is the fact that we don't use the heart-lung machine. So the heart is never stopped. And we can operate on it while it's beating, and we do that without opening the chest. And so those are the two elements that make it significantly less invasive to the patient.
Doctor, I know when I was looking at the alternatives, it was one of those things you look for people out there. There just weren't a whole lot of people that were doing it. And as I mentioned, my introduction to you was simply by fate of my wife running into somebody. Are there more than I think there are out there, or is there a reason there aren't a whole lot of people out there doing robotic heart surgery?
Well, now they're starting to become more and more people. We were holding the line for over a decade when the instruments for this procedure were not made available on the new generation robots. And now finally the makers of the robot have realized that this is something that can be scaled, and surgeons can learn and take the time to train on some of these techniques, which are demanding, and you have to have a lot of patience and you have to go through extra training. So it takes these days it takes about 7 years or so to make a heart surgeon, and that's after medical school. And then basically after that, and after you've gotten some experience doing traditional open heart surgery, you've got to go through some more training. And so not a lot of folks want to do that once they're into their specialty career. And so there's a limit there. But it turns out that because robotics is becoming more and more common in regular surgical operations, whether it's hernia repair or taking your gallbladder out or doing bowel surgery, all those things are done now robotically. And so the people that are training eventually to become heart surgeons are getting exposure. And so the likelihood that this is going to become more widely utilized is happening. We're training a bunch of folks. We just trained a young doctor from Mayo Clinic who just went back there, began in the beginning of September, and he will be doing his own thing. When you were there in 2022, we probably had a junior man that now is in Philadelphia, who is doing his own thing at Lincoln Hospital. Now, there's different varieties of robotic coronary surgery. What you had is what I call the highest form of it, meaning that we use the robot for the whole operation and we don't make any cuts and we don't spread the ribs. There are partial uses of the robot where we use the robot to just harvest that artery, and then the hookup can be done with the surgeon's hands through a small opening in between the ribs. It's a little more invasive, but nevertheless, it's still considered part of the robotic portfolio. And that operation in that form is much, much wider spread than what you had, which is the TPAP procedure.
What was the drive to take you from medical school into heart surgery?
Whoa, how long do you have today?
Hey, I'm the owner here. We could do whatever we want. I do need to reintroduce for those that are listening on the radio and just happen to tune in. This is a podcast. It's the Limbwalkers podcast. You can get it on Apple, Spotify, wherever you get your podcast. We're talking to Dr. Hussam Balki out of the University of Chicago. He performed what was then and still is very revolutionary surgery on the head of this podcast, and that is the Limbwalker podcast. So, you remember the question now?
He was trying to deflect.
No, Doctor, it's just a radio thing you got to do every 10 minutes. But anyways, go ahead and I'm interested in this progression also.
Yeah, so heart surgery in my evolution, if you will, was the thing that I wanted to do from high school. I was lucky enough to get into somebody's operating room and watch them do heart surgery, and it was just fascinating to me. And I thought it was the thing that I wanted to do, and I never kind of wavered from that. And eventually did my training and became a traditional heart surgeon, finished my training in 1997. After which I did everything by the book, as it were, exactly how I was trained: open the chest, make a big cut from the neck to the belly button, saw the chest open in half, stop the heart, do everything. Can you hear me from the sirens? I can turn the...
I can. But
You know what? It's kind of weird, but they don't really come through. We are on a major thoroughfare, and we have sirens all the time. Is that our siren or your siren?
I'm not sure.
Yeah.
But if you can hear me, don't worry.
Yeah, it's not ours. I don't see any right now, so don't worry about it. And also in post, they could take it out if it's really bad. So, keep going if you don't mind.
Yeah. So finished training in 1997, did everything the way I was taught to do it, and then decided a couple of years into it that what we were doing was very invasive, and patients were in the hospital for a long time, and there was a lot of complications from opening the breastbone. Sometimes there'd be infections. Not to mention the fact that it was even short of a major complication like an infection, there could be little clicks that people feel. You can't sleep on your side as much. A lot of times these things heal, and we have new ways to heal them now with plates and screws. But back then we weren't using any of that. Then it became very obvious to me that we were helping the patients by doing some of these operations, but we were also hurting them by the level of invasiveness, and that's the physical hurt. Now, fast forward a couple of years from there, and I started to realize that there was also some psychological hurt. And what that means is that having an operation like this and deforming your body takes a hit on somebody's psyche to the extent that depression can sometimes set in. And we've had lots of experiences with that. When I was a resident in training in surgery and in heart surgery in Boston in the early 1990s, we had a psychiatrist as part of our team. And this is kind of subtle, and I don't know how prevalent this was, but that person's role was to make rounds with us twice a day and tend to the people that had depression, basically, after we did this to them. And it was kind of almost like part of the norm of what we do. And it was part of doing business, if you will. That's how you got to the heart. And so also when I was a resident, the general surgeons started operating with scopes. So you've heard of something called laparoscopic cholecystectomy. And knee surgeons were operating with scopes, the orthopedic guys, gynecologists were operating with scopes. And it became very evident that one could do effective surgery on major body cavities with a scope without opening up the body. And so I started looking into that probably in the early 2000s and started doing some surgeries with a scope, with smaller incisions, avoiding the saw completely. And around 2006 or so, I was in practice in Milwaukee at the time, we had a robot. And it was in the early-ish days of robotics. The very first robotic surgery was done in France in 1998, published in 1999. And it came to the United States immediately after that. But we started our first cases in 2006, and it was a very primitive robot at the time. It was the first and second generations. Now we're up to the fifth generation robot. But basically, that was when I realized that this robot was going to get us to where I needed to be, which is operate effectively, have the same outcomes, and not invade the body as much and avoid a lot of those different complications. Now, that's a tall order, and you've got to really hone your skills a little bit and have a vision as to how you're going to do it. And one of the unique things about my program when we started is that we were doing everything with the robot, not just a coronary or a valve or a congenital defect or something of that nature. A lot of programs kind of chose what they wanted to do. They were just going to do the coronaries, or they was just going to do the mitral valve. But I felt that it was important to have a what I call a multi-spectrum program, and that's what we brought to the University of Chicago in 2013 when they recruited me down here from Milwaukee. And since then, we've had a program which is quite unique. It's multi-spectrum. I only do robotic surgery now. That happened about 10 years ago, where I basically stopped needing to open the chest for anything. We've got referrals coming in for this type of surgery from all over the country because it is so unique. But the good news is that after having done that now for the last decade, the company that makes the robot is back in the game. We're starting some strong training programs with the surgical societies, and they're starting to make the instruments that we need again to execute these cases. So that's kind of in a nutshell, 5-minute just summary.
That was outstanding, by the way. The theme of Will's podcast is, letting go of the limb and then kind of managing how you're going to be when you're out on that limb. And so can you go back to that moment where you knew that you had to walk out onto the limb and you had to try a little bit something different? I mean, at the time, open heart surgery was, pretty prevalent. I mean, it was everywhere. And all of a sudden, you're bringing in a new technology, and I'm sure there might have been a little reluctance on some people's part. Go back to that moment where you let go of the limb.
You mean when they used to call me a maverick and
I'm sure they called you other things, Doctor.
If we can get that video playing, we'll be able to have that.
We'll put that in there. But
that's a nice segue into that video. If you want to go ahead and play that.
We're going to play that. We are going to insert the video here on the podcast right now. Let's have a little bit of silence here. So talk about it, Doctor. You were a maverick, and that is what some people called you, but some folks might have run into some resistance to bringing robotics into the heart in human beings. Talk about that moment when you're trying to get robotics accepted, you're trying to get into it. What was that like?
Yeah, well, I have to say that I wasn't the first one to do it. There were others that preceded us and tried to, use the procedures with the very, very early robots in 2001, 2002 range. But by the time we got into it, it was still kind of, is it experimental? We'd have to call the insurance companies and say, no, this is not experimental. There's some good evidence that this works. There was a study that was done in 2002, I think, that was a relatively positive study. The conversion rate, I think, in that study was something that we would never accept today in the 15 to 20% range. But there was some good evidence, and there was a lot of resistance, and you had to change the mindsets of folks that you work with, whether it's in the operating room or in the clinic. Cardiologists were, kind of new to all of this, and admittedly, when one starts to do something different and something new, you will have the cases will take longer, and the team will, maybe feel that, why don't you just open up this chest and then you can get it done quicker, because that's kind of what we normally do. And you have to persist. So you have to have a team that knows what the relevance of the mission is and why we're doing this. And that's that takes some doing, but the resistance is there, and as you get more and more successful over time, it slowly goes away, and then you start to get more and more referrals and interest. And now we have a collaborative team that is very interested in this, whether it's cardiologists, primary physicians that send their patients for this, physicians themselves who've come and had this as well. So that's kind of the trajectory there of that.
We're talking to Dr. Hussam Balki of the University of Chicago, and he let go of the limb, and he went out and took a little different path with heart surgery that has kind of become a little bit more used, or a lot more commonplace, especially as the instruments improve. Will, we don't want to take too much time for the doctor. What do you want to make sure that people know from the doctor?
The reason I asked Dr. Balki on was, number one, being forethinking enough to walk out on that limb and try for something he knew would be better for patients. Would be more, maybe not more successful, as successful, but with least disruption to a person's life. And I'm an example of that. I mean, I basically, other than the day or two I was kind of grogged out and everything from the anesthesia, I mean, I was out walking in the hall at the hospital the day I had the morning after I had the surgery. Thank God there are people who are willing to take the risk and go out on the limb and try things. It doesn't mean that if you're someone who likes hugging the tree that you should feel bad about that. There's just different levels of results you get based on how far out and to what extent you want to try. And Dr. Balki is an example of that, and I thank him because he helped me with making my life a lot easier. And from one limb walker to another doctor, thank you.
You're welcome. I do want to say, Will, that as opposed to, for example, in the airline business, we say that's a brave pilot was able to land the plane, or that's a brave team on the plane. The difference here is that I heard somebody once say that there's no such thing as a brave surgeon, only brave patients. And what that alludes to is the fact that when we do innovative things, the person that could potentially be at risk is obviously the human being that we're taking care of. And there has to be an eye-to-eye conversation and understanding of exactly what we're doing. And this is the case in any innovation in medicine. It has to happen this way. Whether it is, 50 years ago when people were doing the very, very first heart surgeries, the first heart surgeries that were ever done before even the heart-lung machine was invented was something called a cross circulation, where they connected the circulation of a baby with her mother to fix a hole in the heart. And if you asked anybody at the time, what the heck was that? It was out of the box thinking like nobody's business. And so I think that the pioneers that really innovated were back then, because this was something that was never even thought of being possible. And then they invented the heart-lung machine, and we were able to stop people's hearts and do things. And I think in every specialty in medicine, you'll find the same thing. But all along the way, there has been a conversation with the practitioner, the surgeon, if you will, in this case, and the patient to say, this is something that we haven't done. This is something that is new. You could call it experimental. We've done our experimental work, and we all did in the lab. We did it on cadavers. We did it on, animal models to some extent. But I can remember my very, very first robotic case in Milwaukee in 2006, I believe, is a young woman who came and said to me, I want to get done with the robot. And I said to her, this is my first one that I've trained up on it, and I feel like I can do it. And I think you're going to have a great outcome, but I have not done this before. She says, I have faith in you. And I think those are the real heroes that move the needle forward. And I think Will alluded to that a little bit. But this is a partnership between the interventionalist, the surgeon, and the patient who's subjecting themselves to this. And I think that the patients are what empower us to be able to move forward and use technology for the benefit of future generations.
Limbwalkers podcast, anywhere if you're listening on the radio, you're watching it on the TV, or if you are getting it wherever you get your podcasts, it's called Limbwalkers, L-I-M-B Walkers, and it is Will Glaros's life philosophies of letting go of the limb. Certainly, Doctor, you fall into that category. We can't thank you enough for coming on today.
Thank you very much.
Thank you, Doctor.
Thank you. And what we'll do is, if you can end that Zoom, and we will, Will and I will just reflect for a minute. Will, first of all, there's this stuff I did not know about you. I think we had talked about from the
so
outside.
So you don't know about me? I let a little bit out at a time.
You have let a little bit out of a time. I've had some heart issues, this and that, and then you get a little bit more. And now everybody has a pretty full understanding of what you went through. What was that like?
It was scary. When they tell you that, I had 3 stents put into the left anterior descending artery. And it's probably 15 or 17 years ago, and they had blocked up for a second time. My cardiologist, when he did the angiogram, he said, I don't think we can get another stent in there to keep that open. And I'm saying you probably need to look at the option of doing cardiac bypass. So I talked.
Open heart surgery.
Open heart surgery was what I anticipated thinking.
I can't imagine when the doctor says open heart surgery, or you're sitting there in an office, you're like, oh my God, right?
Yep. You're frightened, and like I said, it was almost the fate of it was incredible. My wife's this fundraising dinner. And she runs into, I'll mention her name, Kathy O'Donnell, who had worked in the surgical operatory at UFC in the heart area. And she said, well, you ought to have him go see Dr. Balke in Chicago. Walked up. The second I sat down in that seat, my wife said the same thing. There was just a sense of utter calm and confidence in his ability to do the job. And we made the date, went in and had the procedure, and I mean, other than the coming off of the anesthesia, I mean, I don't like gagging and all that stuff, and you got that tube down, but that's minor. You hardly know that because the anesthesia is still there. But the result was out and walking almost immediately and back to my physical fitness program 2.5 days later. It's amazing.
A good news story. Like the podcast, and we'll talk a little bit more about it on other episodes, but we're going to end this one. And thanks again, Will, for being so open about your situation. And thanks to you for listening and watching. Until next time, we will see you later.
This has been Limbwalkers podcast, coming to you from the JED TV studios on the campus of Purdue Northwest in Hammond, Indiana. Thank you for listening.